Welcome to the UC Quits webinar, Top 10 Reasons to Address Tobacco, presented by Dr. Eliza Tong. I'm Catherine Saucedo, Deputy Director at the Smoking Cessation Leadership Center at UCSF, and I will be your moderator for today's webinar. This webinar is one in a series of 5 designed to educate providers on tobacco cessation and health systems change. The UC Quits project aims to further reduce tobacco use and exposure, the leading cause of preventable death, by developing a UC tobacco cessation network and e-referral system with the California Smokers Helpline. Headed by today's speaker, Dr. Eliza Tong from the UC Davis, this ambitious project involves all 5 of the University of California Health Science campuses to ensure that every smoker receives support at every encounter. This system-wide collaboration is a historic change in how healthcare providers can ensure that smokers can get help to quit smoking by using the electronic healthcare record. Learn more about UC Quits at www.ucquits.com and the California Smokers Helpline at www.nobutts.org. And now I'd like to introduce today's speaker. Dr. Eliza Tong is an Associate Professor of Internal Medicine at the University of California, Davis. Dr. Tong received her bachelor's, master's, and medical degree at Stanford University. She completed her internal medicine residency at Santa Clara Valley Medical Center, followed by a postdoctoral research fellowship in general medicine at the University of California in San Francisco. She has been a UCD faculty member since 2006 and has conducted research on tobacco control policy and cessation issues since 1998. She leads the UC Quits project, which aims to address tobacco at every encounter through technical modifications to the electronic medical records and provider outreach. Welcome, Dr. Tong.
Thank you. Now, helping someone to quit smoking is one of the best things you can do for your patient's health. But with all the things we as busy health professionals have to do, why should we prioritize this? This module presents 10 reasons why we should address tobacco from both a public health and clinical perspective. And this project, the UC Quits project, aims to address tobacco at every encounter across the 5 UC medical campuses, an initiative funded by the University of California Center for Healthcare Quality and Innovation. This screenshot is of our webpage, www.ucquits.com, and is an easy way to find information you need to help your smoker. So it's a great resource for you during clinic, and you can see the tabs in the middle of the screenshot that you can access quickly. So for today's presentation, we're going to go through 10 reasons, which are not ranked by importance, but rather more the societal to the individual perspective of a clinician. So number 10, we have over 3 million smokers in California. We have been fortunate that California has had a lot of success in tobacco control by pioneering smoke-free laws, and California's smoking prevalence is one of the lowest in the United States at 11.7%. However, due to California's size and diversity, we still have over 3 million smokers. The smoking prevalence is also higher in certain subgroups. For example, certain racial ethnic groups, Native Americans most notably, especially those groups with low socioeconomic status, those with, who are lesbian, gay, bisexual, or transgender, those with low high school or less education, and those with behavioral health and mental health substance use issues. Also on the graph on the left, you can see that those in the rural areas also have higher smoking prevalence rates. What does this mean for California? The costs of smoking in California continue to be very high at $18 billion, as calculated by Wendy Max at UC San Francisco and her team. What they found is that over half of these costs are from direct health care costs. About 40% of them are hospital costs. And just as much with lost productivity related to illness and also premature death. We still have a lot of work in California to do. Number 9 reason, tobacco causes and worsens disease. Now you may have heard that it's been over 50 years since the first Surgeon General's report on smoking and health. And this list below shows all the kinds of diseases that smoking causes, not just cancer, but many chronic diseases. Tobacco is known to be the leading preventable cause of disease and death still, with about 480,000 deaths annually. And we know that this is also important for non-smokers exposed to secondhand smoke, and over 40,000 deaths annually. Added to this Surgeon General list every year are more diseases that are caused by tobacco. So while we've heard of many things like lung cancer or heart disease, other cancers like liver and colorectal cancer have been added, as well as chronic disease like diabetes, type 2 diabetes, and rheumatoid arthritis and other autoimmune diseases. So besides thinking of the diseases caused by tobacco and the deaths caused by tobacco, we also need to consider how tobacco and tobacco smoke exposure worsens treatment. For example, it's been demonstrated by randomized trials that surgical healing is worsened, that tobacco smoke also increases infections, that tobacco smoke also causes less effective treatment, for example, with diabetes and rheumatoid arthritis, and also less effective cancer treatment. So you may have heard of some folks saying, well, I already have cancer, there's not much more I can do, why don't I just keep smoking? There still are plenty of reasons to quit to make your chemotherapy, surgery, radiation, and survival outcomes better. Number 8, there is no safe level of smoke exposure. This was a conclusion from the 2006 Surgeon General's report on the health consequences of involuntary exposure to tobacco smoke. Now, it may come as a surprise to you, but secondhand smoke, the health effects of it is nearly as large as smoking for heart disease. While we're used to thinking of cancer in a dose linear response form, secondhand smoke has a curvilinear dose response where it says that the mechanisms of action are very rapid and cause that large health effect. Why does this happen? It's because there are different mechanisms from cancer. So, for example, endothelial dysfunction in the cardiovascular system, platelet aggregation, inflammation, these things that all trigger those cardiovascular responses and are also important for pulmonary responses as well. Now, evidence has been shown from the tobacco industry that smoke actually gets more toxic as it ages and changes, in fact, up to 16 times per gram. So even though smoke is dissipating, it actually is hanging around, say, on curtains and other things, and carpets. This can also be known as third-hand smoke. As it ages and changes, there are chemical reactions where things get more toxic. So when you think about all of this, you understand that ventilation itself is not a solution. Ventilation cannot get rid of all the chemicals that the smoke leaves behind and all the residue and all the air particles. So the best thing for everyone's health is to have a smoke-free environment completely. Number 7, quitting benefits health now. So while you might hear some folks say, well, Doc, I might just reduce my cigarettes, the main message to get is once you start quitting, within minutes, you will start seeing health benefits. So this infographic on the right is from the Surgeon General, and they demonstrate how within minutes from the bottom where that person is taking their road to health, within minutes you can see symptoms change, heart rate and blood pressure dropping, breathing gets better, and then after only 1 year, your risk of coronary heart disease is cut in half. A few years later, cancer risk is also lowered. So reducing cigarettes, while many patients may feel that is one step towards quitting, it may not be enough. There have been studies that have shown that smokers may actually compensate for the nicotine that they try to get from the cigarettes by how they draw upon the cigarettes or how long they smoke the cigarette. And then there are also people who may have reduced their cigarette consumption but they continue to smoke, maybe not every day, but that this can also be a stable pattern. And as we mentioned before, the cardiovascular effects of smoke are so quick that even this can be a health risk. Reason number 6, UC quality needs improvement. While this is a talk for the UC medical campuses, this in fact actually goes for everyone who's a health professional. So the graph on the left shows results from a 2012 quality report among California's safety net hospitals that actually shows a wide range of rates for tobacco cessation assistance. And we've highlighted here the baseline rates for the 5 UC medical campuses, and these numbers are changing with improved documentation and systems change. But as more attention focuses on tobacco cessation as a quality measure, we need to make sure as health professionals that we are taking action and documenting systematically. And some of these quality measures for tobacco cessation are listed here on the right. We have meaningful use. A core measure is tobacco status. An elective measure is also what kind of intervention was being offered. DSRIP is another prevention measure, which is related to Medicaid pay for performance, and that's where the results on the left came from. There's another quality measure also called PQRS. So these may all be relevant to our institutions as another incentive for us to adopt change. One of the more upcoming tobacco measures is the Joint Commission Tobacco Measure. While tobacco cessation may usually have been thought to be addressed in the outpatient setting, it's very important in the inpatient setting as well, especially for things like cardiovascular or pulmonary readmission rates. So the Joint Commission had changed their tobacco measure a few years ago, and it's much more comprehensive now and has 4 key measures. So one is asking tobacco status. Number 2 is checking to see if counseling and medications have been offered during a hospital stay. Number 3, to see if counseling and medications have been offered at discharge. And finally, number 4, that smoking status has been followed up after discharge, about a month after discharge. And the reason for that is while most people are so sick that they need to be in the hospital and they stop smoking, by the time they go back home, we know that that's a very important time when people relapse in their usual environment. So we need to think about continuity of care, not just in the outpatient setting, but also inpatient as well. Number 5, UC has a smoke and tobacco-free policy. Now, in January 1st of 2014, all the University of California campuses, undergraduate and medical campuses, have gone smoke and tobacco-free. What does smoke and tobacco-free mean? It means no smoking on campus grounds, no tobacco products, including smokeless, and also e-cigarettes are included as well. For more information about how to talk to smokers and additional training materials, you can go to the University of California Office of the President's website, and this link shows how to talk to people on campus who, for example, who are visitors. Many medical campuses now also have a similar smoke and tobacco-free policy. So enforcement of these policies is a very tricky thing, especially when people are very stressed and vulnerable, whether they're patients or they're visitors. So it's very important to understand, as health professionals, we have an important role to support this by offering nicotine medication to hospitalized smokers. Now, one way to think about this is an analogy to pain. When people have withdrawal symptoms from nicotine, they can feel anxious, they can feel very irritable, and so we should also consider this as something that can be treated, especially within the first few days after stopping a cigarette. So what do we have to offer? Oftentimes it's nicotine gum or lozenge, which can be thought of as a short-acting agent, much like we do for pain. And for those who smoke on a heavier basis, there are nicotine patches, which take at least an hour to start getting absorbed into the system, so we should think of this as a long-acting measure. Number 4, cancer screening is important, but also needs next steps. You may have heard that the U.S. Prevention Task Force has come out with the new recommendation based on randomized trial evidence that lung cancer screening can improve mortality rates with low-dose computed tomography. Now, this recommendation is for adults ages 55 to 80 years old who have a 30-pack year smoking history, who currently smoke, or have quit within the past 15 years. Now, implementation of this recommendation is still underway, and there still need to be studies about who best qualifies for this kind of screening. It's not exactly a blanket recommendation just yet. The older you are, the more likely you are to benefit from screening. However, the key thing is if we are identifying these smokers and former smokers who may be likely to quit, to relapse, we need to not just screen them, but we also need to help support them, whether it's supporting with quitting, assistance and referrals, or also to make sure that they have the support so that they do not relapse. Now, you may see on the images on the right are just to remind you that people do live with disease after they've been diagnosed with cancer. And many of you may know Debbie Austin, who was featured on many of the tobacco control ads. And she was a very powerful motivator for many people who eventually did quit on her own before she passed away. So some of these motivational messages can be found also on the California Department of Public Health's website, tobaccofreecalifornia.com. Number 3, smoke interferes with medications. As health professionals, a lot of what we do relies on effective medications, but this is probably one of the lesser known facts that smoke interferes with medication metabolism or action. Psychiatric medications, for example, are affected because cigarette smoke induces the P450 enzyme system, which also metabolizes these same medications. So for a full list of affected medications, you can visit our www.ucquits.com website under our medications tab, and you can see the list of medications affected that have been from the rxforchange.ucsf.edu website developed by the UCSF pharmacy team. Number 2, quitting can take multiple tries. Now, quitting is one of the most difficult things for a patient to do because not only do you have addiction, but you have a behavioral routine wired in with that addiction. Relapse is very common. If a patient is very stressed or something happens in their life, they still remember what that cigarette had done for them years ago. And I find very often that people remember the exact day that they had quit because it was such a powerful and difficult thing for them. So at times, though, a patient may feel like that because they couldn't quit and relapsed, they may feel that they are a failure or that it's not worth it to try again. The way I do this is I try to reframe it for them to say that they need to keep trying and that it may actually be easier the next time because if they have quit at least once, they've given their brain a break from the nicotine addiction, and it may actually get easier the more they try. So 70% of smokers do want to quit, and studies show that it may take at least 8 to 12 tries before really quitting for good. So just once or twice may not be enough. And when we think about ourselves as health professionals on this whole health care spectrum, we need to realize that every clinical encounter is an opportunity for someone to be reminded that, yes, they can quit and yes, there is assistance for them there. And finally, number 1, health professional advice helps. So studies have shown that health professional advice actually doubles the odds of quitting. And you can see on the graph on the right just how health professional advice compares to doing it by themselves or with self-help material. And this has shown that people will quit at least for 5 or more months just from someone's trusted advice. So not only is it important for how your advice might help them, it also helps patients' perceptions of you. And there have been studies that have shown that smokers that their patient satisfaction scores for their providers increases too, regardless of how ready they are to quit. They feel like they have gotten comprehensive care even because you've addressed it. And we need to recognize not only is it important to take care of the patient who smokes, but we also need to be mindful of the non-smokers who are exposed to smoke, especially in the pediatric setting. We need to make sure that we address parents and caregivers and provide supportive resources for them too. It's so important. So finally, what can you do? You may have found that you have your own reasons or motivations for helping someone to quit tobacco. We want to make sure that you yourself are supported as health professionals. So add www.ucquits.com to your bookmark links, and we have tried to make it very easy for all health professionals to have access to some of the information about how to help someone to quit. And certainly there is a vast amount of information out there, but this is just a brief start to get people help right away. And finally, here's a summary slide of the top 10 reasons to address tobacco. Again, hopefully you have found your own reason, which very well may be your own patient, and I find often that sometimes the patient stories are the ones that are the most moving. Thank you very much for this presentation.
Thank you, Dr. Tong, for your presentation on the top 10 reasons to address tobacco. You leave us with no excuses. Free CME and CEU of up to 0.25 credits will be available for those who complete this online activity, and the webinar link and instructions to claim credit for this and other UC Quits webinars will be posted on the UC Quits and CME California website. Thank you all for your time. And if you have any questions for the UC Quits project, please contact Dr. Eliza Tong. Again, thank you.